Well, here we are back for part 6 of chapter 44. You made it. You finally made it to part 6. This is the last part of chapter 44, but it is pretty action-packed. There's quite a bit to this part. We're going to talk about burns. We're going to talk about some trauma. We're going to talk about some behavioral issues, fever issues, and then we're going to wrap it up with some little ones that oftentimes have some special needs that, is quite often something that we'll wind up running on and we'll have to take care of. And if you're not really prepared for that, it can be a big surprise to you. So let's go ahead and get started so we can get you through this. So we're going to start off talking about some behavioral emergencies that we might come across, how we're going to assess and manage those along the way. So children with behavioral and psychiatric problems such as out of control behavior, suicide attempts, those kinds of things are pretty commonplace and are often encountered in the EMS setting. EMS calls for behavioral emergencies are on the rise, with about 22% of children aged 13 to 18 having experienced some form of a serious mental disorder at some point, either currently or in the past. And this is this number here is a relatively old number, that 22%. This number is probably higher, though I don't know how much higher, since COVID. The COVID lockdowns and some of those kinds of things resulted in a lot of other behavioral issues among children and even adults that we're starting to see, or we've seen over the last few years. Many of these issues may begin as simple complaints that are not easily recognized by healthcare providers, and if not treated appropriately, these problems often can persist on into adulthood. There's been growing attention from medical professionals towards mood disorders, anxieties, and other behavioral issues in children and adolescents. Of course, suicide is the second leading cause of death among adolescents and children aged 10 to 14. Children are also more likely to have coexisting conditions such as attention deficit hyperactivity disorder, conduct disorders, oppositional defiance disorders, alongside some of the more traditional mental health disorders that we see out there today. Of course, as with any call, and especially those that involve behavioral issues, your primary focus is always going to be safety. Approach the child in a calm manner and clearly explain that you're there to help. When obtaining a history, address the patient directly as much as possible and explain what you're doing and why. Some children may be at risk of running away, so you need to kind of keep that in mind. And assess the situation to determine how to position your team to prevent the child from leaving the scene. Of course, always be honest when answering questions from the child or their family members, and don't lie to them. A small number of children may not be safely calmed down for transportation and might need to be mechanically restrained for the safety of everyone involved. This may require assistance from EMS or law enforcement. Of course, anytime that we're restraining somebody, we should probably enlist the assistance of law enforcement, and especially supervisors. Ensure that the reason for the restraint is carefully documented, and keep the restraints in place until the child arrives at the emergency department. Don't ever take them off. Chemical restraint should be avoided whenever possible. And if you do have to resort to that, of course, you're going to be involving medical control in order to even begin the process of that. Assessment and management of these children, of course, diagnosing mental health issues in children can be quite challenging. So the cause of these issues may include things like organic factors. It could be that that's just the way their brain is growing. It could be some genetic factors involved. Of course, there's almost always some form of environmental factors involved in those as well. Cultural and ethnic influences can also complicate the distinction between normal and abnormal coping skills that these children have, so it further complicates the issues. Abnormalities found during the developmental and mental status exams are often linked to adjustment disorders and stress. It is essential to assess the suicide risk in every child because so many of them are at high risk of that. The pediatric assessment triangle provides a general overview of the child's mental status and cardiovascular stability. So this will be a really good starting point. And remember, this is something that we can perform without even touching the patient. We can do this from a distance. A child who has attempted suicide through ingestion may experience a life-threatening medical complication, and that may need to be addressed more urgently before the psychiatric concerns can even be broached. If there are no immediate medical issues, the focus of your assessment will primarily be on the observation and history gathering related to the behavioral issue. When dealing with an agitated child, physical assessment may be difficult at best, and it may be very limited. Treat any medical problems or injuries using your standard protocols. All right, so management of fever emergencies, while not real common after a certain age, fever emergencies are pretty common in the younger children, say under 6 or so, but if we do have fever issues in children older than that, it may be something a little bit different, which we'll get into that a little bit. Fever is a common concern in pediatrics, but it's typically not considered a true medical emergency. Fever is often a symptom of an underlying infection or inflammatory process and can have various causes. Most fevers in children are caused by viral infections. These infections are often mild, and typically they are self-limiting, meaning they've got a certain amount of time, and once that time frame for those passes, that the virus leaves the system and the fever goes away. Occasionally, a fever may signal a more serious bacterial infection, and with those are not typically self-limiting and oftentimes require the use of antibiotics to get those under control. The general impression and primary survey can help assess the severity of the fever. Young children with a fever can sometimes appear to be quite ill. Record the temperature. If you're able to take the temperature, be sure and record it. Though it is important to remember that the height of the fever does not necessarily correlate with the severity of the illness. So doesn't necessarily, they can have a very high fever and not be all that ill, and vice versa, they can have a low fever and be quite ill. For young infants, a rectal temperature is the most accurate method of measurement. Watch for signs of respiratory distress and things like shock, seizures, stiff neck, rashes, or even a bulging fontanelle in infants. These signs may indicate the presence of conditions such as pneumonia, sepsis, or even meningitis in worst cases. All of these conditions, of course, can be life-threatening and are going to require prompt transport. Infants under 2 months of age should always be considered at risk for serious infection. Fever in these infants may be the only indicator for potentially life-threatening illness. Regardless of how well the child appears, it is important to assess and transport quickly. And remember that we're talking about infants of 2 months of age or less. If they've got a fever, they need to be transported. Any child younger than 28 days with a fever, and most children under 2 months, will typically require an admission to the emergency department for further evaluation. So that's why it's really important that we transport them. History taking and secondary assessment are crucial in determining the underlying cause of the fever and assessing the severity of the illness. Perform this on the scene if the child is stable, or en route if the child is seriously ill. Inquire about symptoms such as vomiting, diarrhea, poor feeding, headache, neck pain, stiffness, and rash. A history of infectious exposure can provide important clues about the cause of the current illness. So if they've been exposed to others that have been sick, this will be helpful in determining maybe what's causing this sickness. The history may also help identify children who are at high risk for serious bacterial illness, including conditions such as sickle cell disease, HIV infection, childhood cancers, all of which can lead to an immunocompromised state for the child. A child with a fever may require minimal intervention though. Of course, we're going to support ABCs, provide temperature control as much as possible. We can consider giving a acetaminophen or ibuprofen, but we should always avoid giving aspirin to children. Of course, acetaminophen and ibuprofen is going to be protocol dependent, and you may have to get medical control in order to do that. We don't give aspirin because it's been linked to Reye syndrome, and this is a rare illness that can lead to cerebral edema and ultimately liver failure. We want to limit other cooling measures to simply disrobing or undressing the child and exposing them to air so that their body will naturally cool. Transport the child to an appropriate medical facility for further evaluation and treatment of their febrile condition. Child abuse and neglect is a relatively common thing that we run into. We see quite a bit of this. We'll spend a little bit of time here, probably a little more time than some of the other topics, at least until we get to trauma and a couple of others. So, child abuse encompasses any proper or excessive actions that harm or injure a child or infant, including physical, sexual, and emotional abuse, as well as neglect. Neglect is considered a form of abuse. Child abuse includes physical abuse, sexual abuse, emotional abuse, and neglect. In 2019, state agencies reported an estimated a little over 1,800 child deaths resulting from abuse and neglect, which averages out to about 5 children per day, every day of the year. Over 70% of the children who died due to abuse and neglect were 2 years old or younger. More than 80% were too young for kindergarten, and around 80% of child maltreatment fatalities involved at least one parent as the perpetrator. So these things almost always hit close to home. Definitions of abuse that we're going to use here, of course, are physical abuse, and that's inflicting injury on a child. Sexual abuse kind of speaks for itself, but basically it's when an adult engages in sexual activity with a child, which can range from inappropriate touching all the way up to intercourse. Emotional abuse and neglect, these are forms of abuse that are often difficult to identify and may go unreported for a considerable amount of time. Neglect, on the other hand, is failure or complete refusal by the caregiver to provide the basic necessities for the child's survival and well-being. And then, of course, emotional abuse, is that lack of emotional support and nurturing from the caregiver. And this is going to fall kind of in with the emotional abuse and neglect. You can have emotional abuse that are abusive and things mean are said, and then you can have emotional abuse that is due to the complete lack of emotional support. So those two kind of overlap, and they intertwine kind of with neglect as well. So all those are all very difficult to distinguish and very difficult to determine. Abandonment occurs when a parent or guardian leaves a child behind without regard to the child's health, safety, or welfare. Abandoned children, also known as foundlings, may be found in homes where the parents or caregivers have left them without proper supervision, may be dropped out of a public place such as a park, street, or public pool, where someone else can find them. When a child is abandoned, parents have relinquished consent authority, so EMS providers should render care without needing written or verbal consent. Safe haven laws allow parents to leave their children at designated locations without facing legal consequences, and the children become a ward of the state. Children may be left unharmed by caregivers at the following locations: police stations, fire stations, hospitals, and specialized infant boxes. All 50 states have enacted safe haven laws, although the specifics can vary a bit from state to state. Keep the possibility of abuse in mind with injured children. We always want to take that into account, that there may be abuse involved. Information you gather from your scene size-up and interviews may be critical in identifying the potential for abuse. If it is suspected, make sure that you act on it. You have a legal obligation to report it. A child who is abused once is likely to be abused again, and the next instance may be much more severe and possibly even fatal. There are some risk factors for abuse. Typically, younger children are more vulnerable. Children who require extra care or attention, such as those with disabilities, chronic illness, or other developmental problems and special needs, are at a much higher risk. Abuse occurs in all socioeconomic levels, but is more prevalent in the lower socioeconomic families. Family stressors such as divorce, financial difficulties, and even illnesses can add to this. And of course, the use of drugs and alcohol in the household further increase the likelihood of abuse. And if there is domestic violence, spousal violence happening in the home, it's very likely that that abuse can spill over to the children. When you suspect abuse or neglect, trust your instincts. Make sure you just trust what you're seeing. Look for those red flags, and you can use the mnemonic. There's a mnemonic called child abuse. History inconsistent with the type of injury that you're seeing is also a pretty good indication. An account of the injury that doesn't actually line up with the abilities of that particular child, such as a 2-month-old infant rolling off the bed or something like that. That's just not typically what would happen with that particular developmental stage of a child. Unreported old injuries, so bruises in various stages of healing. Inappropriate actions or language from the caregiver. The caregiver's not acting or behaving appropriately or saying the right things. Signs of child maltreatment are summarized in the child abuse mnemonic that you see here kind of on your screen there. So recognizing abuse begins by suspecting it. So you need to just kind of suspect it and then start to vet it out. And then you can use this child abuse mnemonic that's here on your screen. It's also in your textbook. So you should be able to find it in there in chapter 44, kind of towards the end of the chapter. Carefully document what you observe, but try to remember to stay impartial even though you have a high indication or high suspicion that there may be some abuse going on. Record all observations in a detailed incident report. Include notes about the child's environment, the condition of the home, interactions among the caregivers, the child, and the EMS crew. Document any concerning comments verbatim, noting who made them and when and why they were made. In every state, pre-hospital personnel, like I mentioned before, have a legal obligation to report any suspicion of child abuse to protective services and law enforcement. So if you suspect it and you're seeing signs of it, you have a legal obligation to report it. Failure to report could be seen as a crime, so it's important to familiarize yourself with the various state laws where you may be working. Reporting is typically done in collaboration with emergency physicians, social workers, and child protective teams at the emergency department. But if you suspect it, you can easily begin to involve law enforcement early on in your care. In cases of death, the medical examiner will investigate the cause of death. Notify the medical examiner of any death, especially if the child's not being transported to the emergency department, which is pretty standard. You know, any death of a child is almost always going to be a medical examiner case. There are some exceptions, you know, if a child has a long medical history of illness and that has a poor prognosis kind of thing, those may or may not go to a medical examiner. Sometimes they still do. Make sure you address your concerns with the other staff, not the caregiver themselves. Stay informed about local regulations regarding the abuse and neglect reporting. Remember, the scene may be very emotionally charged, so focus on the patient assessment and management as well as ensuring the child's safety. Remember, safety is going to be a concern. Once you know that you're safe, your partner's safe, other responders are safe, then we make sure that the child is safe. Base your general impression on that pediatric assessment triangle, which may range from normal to really or grossly abnormal. Shaken baby syndrome may present with an abnormal appearance and no external signs of injury, especially if it is something that has just happened. Very few caregivers are going to admit to hurting a child, so be cautious of any history that doesn't match the clinical findings that you're seeing. Look for bruises, particularly if they are in various stages of healing or in unusual areas. Very active toddlers may have bumps and bruises on their shins, but it's uncommon for them to have bruises on their back or back of their legs or buttocks. Bruises that form an identifiable pattern are rarely accidental, such as hand marks or those kinds of things. Of course, that child abuse mnemonic that we looked at earlier, that you saw earlier, we can use that to gather more information during the history taking phase to help us kind of determine whether or not there's abuse pattern showing up. There are some things that can mimic abuse. Sometimes it can be hard to tell the difference between normal skin marks and injuries caused by abuse. There are such a thing called Mongolian spots. These are birthmarks that are typically found on the lower back and around the buttocks in children of Asian or African American descent. Mongolian spots can easily be mistaken for bruises due to their distinct bluish color that look very much like bruises. So if the bruises look large, but it's just not really adding up to what is going on. And sometimes parents, when if you first see the bruise, sometimes parents are very quick to tell you, those are Mongolian spots, I don't beat my child. Of course, if the rest of things don't add up, you're going to have to move on to that suspicion that maybe they are. Some other medical issues can look like bruises, which makes a diagnosis a bit tricky. Kids with meningitis or some other issues can develop purpura that looks a lot like bruising, so they can have those red marks. Small red, purple spots from conditions like leukemia can be confused with bruises as well. Sometimes sunlight can cause skin reactions when mixed with certain medications or fruits like limes or mangoes. And then we could have a phototodermis dermatitis reaction that can leave a reddish purple mark that looks a lot like bruises as well. There are some cultural practices out there that can mimic, and some cultural practices and traditions that can mimic abuse marks. These can leave marks on the skin that look a lot like abuse. The picture you see on your left is a kind of a coining technique where they use a warm coin and they rub it repeatedly over the body in certain areas. Cupping is also pretty common in Asian cultures, although this is becoming a much more common technique to actually be used in a lot of physical therapy. They're doing cupping actually in treatments for athletes in high school as well. So it's not uncommon to see these round marks, and they may be bright red or they may be bruised, depends on how old they are. Appearance versus harm, you got to kind of weigh that. While the marks can look dramatic, these practices are not considered harmful. And many cultures actually use these, not to mention training programs use the cupping as well. What the cupping does for an athlete, it kind of it helps to separate the fascia from the muscle so that the muscle has a chance to heal, and it kind of makes the muscle kind of relax. So it does a few things for an athlete that's recovering from a sports injury. SIDS, or sudden unexpected death, we used to call it sudden infant death syndrome, sudden unexpected death. So SIDS is basically a death of an infant younger than 1 year old that occurs suddenly and unexpectedly, the cause of which is not immediately obvious for the investigators. Most SID cases are classified as sudden infant death syndrome, unknown cause or accidental suffocation, and possibly even strangulation in the bed. SID refers to that sudden death of an infant under 1 year old that remains unexplained even after a complete autopsy. A detailed death scene investigation and the review of the baby's medical history, none of that reveals anything that is an indication of why they died. So these cases are often classified as sudden infant death syndrome. This used to be called crib death. So, I mean, it's just another name, but it's the same. In 2015, around 1,600 infants died from SIDS in the United States. This is the leading cause of death for infants between 1 and 12 months old. A death may be labeled as unknown cause if the infant is under 1 year old and the investigation was incomplete or inconclusive. Accidental suffocation and strangulation in the bed can cause sudden infant deaths due to the soft bedding, someone rolling onto the infant, or the baby becoming trapped between objects. These deaths are oftentimes very devastating for families, and they can deeply affect EMS crews who respond to them. So if you ever run on a SIDS death, you're going to remember it for the remainder of your career, because oftentimes the parents are young parents, maybe first-time parents in their early to mid-20s, and they are completely shocked at what has happened, and they've basically just found their baby dead in the crib, and they've called you for help. And you know, it's not a pleasant scene to have to deal with. A typical SIDS call involves a healthy infant who was put down for a nap and later found unresponsive in bed. When you arrive, the infant is usually lifeless and may show signs of rigor or even lividity depending on how long they have been down. It's common to see frothy or blood-tinged fluid around the mouth and nose or on the bedding. But be alert for signs that could suggest other causes of death, such as trauma, suffocation, or maybe even abuse. The decision to begin or stop CPR can be really tricky with these and should follow your local protocols, considering both medical findings and the family's emotional state. Even if the infant cannot be resuscitated, not initiating care may be distressing to the family. Hospital-based social services can actually provide a lot of important support for grieving families, so it may be best to go ahead and transport the infant to the hospital while initiating care so that the families can get some help as well. If the case meets criteria for declaring death at the scene, make sure that you notify the coroner, medical examiner, law enforcement as required by local guidelines. Offer emotional support to the family by giving chaplain, minister, social worker, or SIDS support team. Many police departments have a police chaplain. Conduct a thorough scene size-up history to help determine if the death could have come from another cause. And of course, a recent illness or chronic medical condition or evidence of trauma may suggest something other than SIDS. Items like pillows, stuffed animals, cords, things like that may point to suffocation as a possible cause. A brief, resolved, unexplained event. This one had me curious as well, but let's go ahead and talk about it. A brew involves an infant suddenly becoming pale or blue, choking, gagging, or having an apneic episode or going limp. This condition was previously referred to as an apparent life-threatening event. It's since been changed to a brief, resolved, unexplained event. Causes can range from harmless to serious medical conditions. Benign causes include a brief laryngospasm during feeding or some gastroesophageal reflux. Serious causes may include infections like sepsis, heart defects, and seizures. Brew was once thought to be related to SIDS, but current research shows that the two are not really connected, so SIDS and brew don't really go together. It's common to find a very distressed caregiver with an infant who appears to be normal by the time EMS arrives. So, you know, you see a very stressed out caregiver and a baby that's kind of looking around going, what's all the fuss about? But it creates a lot of panic among the parents or the caregivers when this happens. Of course, if necessary, provide life support if the infant shows signs of breathing problems, poor circulation, altered mental status, that kind of stuff. Always transport an infant with a history of brew, even if they appear to be doing well at the time. They need to be assessed. Infants in this age group are difficult to assess, so it's safest to over triage. Bruise can sometimes indicate a serious underlying condition, hence why they need to be transported and assessed by a physician. Choosing not to transport the infant could lead to more severe consequences, so try your best that you can to convince the parents that the child needs to be seen. Ideally, EMS transports them, but they may want to transport themselves. All right, so let's talk a little bit about pediatric trauma emergencies. Children, of course, we talked about this way back 5.5 sections ago, that children are different than adults. Their anatomy is different. But remember, this does lead to different injury patterns and responses to trauma, and kind of how they get themselves into trouble when it relates to trauma, and how that's very different than adults. Of course, their developmental stages are going to influence how they respond to these injuries and how we should assess them as well as treat them when it comes to traumatic injuries. Blunt trauma is the most common mechanism of injury. I'm trying to blend words now. So blunt trauma is the most common mechanism of injury in pediatric trauma cases. Children have less muscle and fat mass, which provides less protection against the forces of trauma. Remember that fat mass and muscle mass actually acts as a cushion to prevent further injury. Children don't have those, so falls are common, and they're a common cause of injury, and the nature of the injury depends on the child's anatomy and the overall height of the fall. For example, a 6-year-old falling from the monkey bars is most likely to break an upper extremity when landing on an outstretched arm, and internal or head injuries are unlikely with this type of fall because they can typically get their arms out in front of them to try to catch themselves. An infant, due to their large head and a lack of any kind of organized protective reflexes, is much more likely to sustain a skull fracture and potentially have an intracranial hemorrhage if they fall from a shopping cart. So kind of keeping things into perspective and understanding, the differences in the development as well as the way their bodies are made is going to help us with that. Falls from a standing position usually result in isolated bone fractures or even just bumps and bruises. High energy falls, such as from significant heights, can cause multi-system trauma in all ages. Injuries from bicycle handlebars often lead to compression injuries of the abdominal organs, duodenal hematomas, pancreatic injuries, and upper extremity fractures are common with this particular mechanism. Always consider a head injury if the patient goes over the handlebars, especially if they were not wearing a helmet. Motor vehicle crashes can cause a wide variety of injury patterns, and of course a lot of it's going to be based on the type of restraint used and the child's position in the vehicle as well as where the damage to the vehicle is. For unrestrained passengers, we should always assume multi-system trauma due to the lack of protection. Restrained passengers may experience chest, abdominal injuries due to the seatbelt. If there's chest or abdominal bruising in a seatbelt pattern, suspect spinal fractures as well. Airbags can cause serious head and neck injuries, especially in young children. That's why we keep them in the back seat. Car versus pedestrian collisions are likely to result in multi-system trauma, and they're going to be age and height dependent, where the vehicle is going to make contact with them. Chest, abdominal, lower extremity injuries are typical of occur with impact injuries of these cases. So we see a lot of them because the bumper catches them, bumper in the grill. Head and neck injuries may occur when the child's thrown from the vehicle during the collision. So very common to see those types of injuries. So assessing them. All right, so scene size up, making sure that all of our safety things are addressed. Look around for the mechanism of injury. And of course, get a head count, find out how many patients we're dealing with, and then follow standard precautions. Use that pediatric assessment triangle to get your general impression. Remember, we can do that from a distance as we're approaching. If we find if the findings are really out of the normal, we're going to have to move quickly with the ABCs. If they're abnormal in appearance, consider a head injury. Remember, with a closed head injury, breathing and circulation may still seem normal early on. An abnormal appearance may also signal inadequate oxygenation due to shock or respiratory failure. And then, of course, if we've got breathing issues, it may indicate chest or airway injuries or even abnormal circulation that could suggest hemorrhage. If there is multiple systems injured, all three patient assessment triangle categories may show abnormalities in those patients. Immediately, if you need to start those life support interventions, and of course check the airway for obstruction such as teeth, blood, vomit, that kind of stuff. Suction is needed. Use jaw thrust maneuver if there's spinal injury that's suspected, just like we do with adults. If they can't maintain their airway, consider an NG or oropharyngeal airway to try to get things under control. If you wind up attempting to intubate, make sure you keep cervical spine precautions in place. Be aware that emergency surgical airways in children have a very high failure rate, and there are several complications associated with that. So the smaller they are, the less likely that a surgical airway intervention is going to be a practical consideration. Tracheotomy should be done only by surgeons in a controlled setting. So up until these probably getting up more into the adolescent stage is probably not something we're even going to consider. Needle crack is unlikely to be needed, but may be considered. So if you got to crack them in the field, it's probably going to be through a needle. But it can be tough to identify that cricothyroid membrane in younger children. So remember that those things are just not really ideal in the field. Of course, provide supplemental oxygen, ventilate as needed, and of course, as mentioned, get good control of the airway. A pneumothorax is pretty rare in pediatric blunt chest trauma, but can occur with penetrating trauma to the chest or the upper abdomen. Jugular vein distension, tracheal deviation are less likely in children, and if it does show up, it's much more difficult to see. If the mechanism of injury suggests a possible tension pneumothorax and the child is in significant respiratory distress, go ahead and perform a needle G compression. Some signs that we might see with the pneumothorax, of course, are going to be tachycardia, difficult ventilating despite having a good open airway, absent or decreased breath sounds on the affected side. We might see some jugular vein distension, but again, it might be difficult to see on the younger ones. And if there's hemorrhage present as well, we may, the veins may be flat because of hemorrhage. Hyperresonance to percussion is a good indication on the affected side, so check for hyperresonance. Tracheal deviation away from the affected side is a late sign, but as I mentioned before, it may not always be present, and it may not always be accessible, and accessible, we may not be able to see it. Pulsus paradoxus is also something that we might see. So when we've got this tracheal deviation, hyperresonance, pulsus paradoxus, and a decreased breath sound, this can be very challenging to assess all of those things in young children. But remember, tracheal deviation is a late sign, but we want to use, when we're doing this procedure, use a large bore IV catheter, about a 14 or 16 gauge for needle decompression. Locate the second or third intercostal space in the midclavicular line on the affected side. Insert the needle at a 90-degree angle just above the third rib. The reason why we go above the rib is because all of the nerves and vessels run on the underside of the ribs. So we're going to do that procedure on the top side of the ribs, so we're not hitting any of those vessels or damaging the nerve that's present there. Midclavicular line, 14 to 16 gauge. is where we're going to place that. Any trauma patient should be considered at risk for developing shock, so we want to keep our eye out for that. Assess circulation by checking pulse rate and quality, looking at that capillary fill, watching skin temperature and blood pressure. In pediatric patients, an elevated pulse rate may be the only sign that they're in compensated shock. Children have a really strong ability for peripheral vasoconstriction and can maintain a blood pressure despite significant amount of blood loss. It's important to realize, though, that once their compensatory mechanisms begin to give out, they're going to crash quickly. That's why it's very, very important that we recognize compensated shock early and begin the process of making corrections for that. So if the mechanism of injury is concerning and the child's tachycardic, assume that they're in compensated shock and begin volume resuscitation with 20 mils per kilogram of isotonic solution. Ideally, you'd want to get 2 IV lines, but an IO line may be the best choice in these really shocky kids. Make sure we control any external bleeding, kind of more or less goes without saying. Once you've got the ABCs stabilized, continue to assess for that, AVPU and that kind of stuff, those disability issues. The pediatric assessment triangle assessment will have already identified altered level of consciousness, but we can keep coming back to that. And just for a quick update of how they're doing, if they're improving or if they're getting worse. Check pupils for motor function to further evaluate any kind of suspicions for neurological status as well. You can use a C-collar to ensure spinal motion restriction on a longboard as needed if it's indicated. If increased intracranial pressure is concerned, keep the head midline to support jugular venous return to the heart. If the child is not in shock, elevate the backboard or head of the stretcher by about 30 degrees. Perform shock resuscitation with IV fluids. If there's signs of acute herniation, such as a blown pupil or Cushing's triad, consider a mild hyperventilation to maintain end-tidal CO2 of 30 to 35. And there is a possibility that you could be asked to administer mannitol, or mannitol may be administered in the hospital setting. Most ambulance services don't carry mannitol anymore, but if you're on a high-level service that does, that might be indicated in this particular place. Conduct a rapid exam to identify all injuries. Log roll the child to check the back and buttocks. Cover the child with blankets to maintain warmth. Be sure to cover the head, especially in infants and children. And consider using warmed fluids or warm oxygen whenever possible. And then, of course, treat fractures as you would an adult. Remember, while fractures, extremity fractures may be very distracting for you, especially in a child, remember we need to focus on the more critical areas first, and fractures may be some of the last things that we get to be able to treat and splint, because we may be managing a more critical patient. Some trauma cases are load and go, of course, because of the severity of the injuries. So we want to make sure we get a good look at the mechanism of injury. Even if the child appears to be stable on scene, we need to take a look at the mechanism of injury. If they're unstable or have a compromised airway, if they're in shock, breathing difficulty, or if they have severe neurological instability, or if they're when we look at that mechanism of injury and it's a significant medical injury and our child is stable, we're going to still be a load and go situation. Perform life-saving procedures on the scene, and then do everything else en route and transport the child quickly to a trauma center or a pediatric trauma center, depending on which of the two that you have available to you. All trauma victims with suspected spinal injury are going to receive spinal motion restriction. Avoid using a C-collar that's too large for small children. Instead, use a towel or rolls and tape to restrict head motion. Apply tape across the temples and forehead. Avoid taping around the chin or the throat as it may interfere with ventilations. Remember, their anatomy is a little different, so we're going to have to take a little different approach. Use a pediatric immobilizer with recess to accommodate for the child's large head. For infants and toddlers, place a towel or small blanket under the shoulders and back to prevent neck flexation. The nearest appropriate facility for transport depends on local protocols, capabilities, and the capabilities of the local emergency department. So if you live in an area with a level 3 or 4 trauma center, you may want to move on up the food chain to a level 2 or maybe even a level 1 trauma center, depending on the severity of the patient. If the patient's stable, gather additional history and perform a more detailed physical exam. For trauma patients with that really significant mechanism of injury, you're going to do a full body, back to front physical exam en route to the hospital. For infants, of course, be sure to check that anterior fontanelle for bulging. That'll be a good indication that there may be the potential for a head injury. Look for bruises, abrasions, or even subtle injuries that may have been missed, or some of those injuries that may be developing or growing as you're transporting. Airway management and ventilatory support should take priority over all else. Tachycardia is often a first sign of circulatory compromise in a child. And remember, this can also be caused by agitation, fear, or even being restrained. So take that into consideration. Hypotension is a late sign of pediatric trauma, and that is not what we want to get to before we treat it. Recognize circulatory compromise early and treat it promptly, because as mentioned before, they can maintain stability for quite some time. When we're trying to get, or when we're establishing vascular access on an injured child, think about using large bore IV catheters in large peripheral veins whenever possible. For infants and young children, we're going to use a 20 to 22 gauge IV needle. Those are considered large bore. Don't delay transport to start an IV line. Perform it en route, since definitive care can only be given at the emergency department. I'm going to back up just 1 second though and talk about the catheter size. Ideally, you want to get at least a 20 gauge catheter in most of those, especially if you're living in an area that allows blood to be given to children for trauma in the pre-hospital setting. I realize many places are not giving blood to children yet for trauma, but as that begins to evolve, we're going to start seeing that more and more in the pre-hospital setting. So a 20 gauge catheter would be ideal for that if you're working somewhere that does administer blood in the field. Of course, to maintain perfusion, administer a fluid bolus of 10 to 20 mils per kilogram of an isotonic crystalloid. Reassess vital signs and give additional fluid boluses if there's no improvement. You can give up to 60 mils per kilogram for pediatric resuscitation. If the child weighs over 50 kilograms, of course, use adult fluids, because that's going to put them up around 100 pounds. If no improvement after 2 boluses, then severe blood loss is pretty likely, and the child may need surgery. So that's when you're going to make sure that you transport them as quickly as possible, and you may even change destinations because knowing they're going to need surgery. If the child is hypotensive and IV can't be obtained within 90 seconds, consider getting IO access, because it'll work just as well. Pain is often undertreated in young children, so be mindful of signs of discomfort. Consider pain assessment as important as the vital signs. Use tools to help you elicit the child's self-reporting of pain. Tachycardia, inconsolability may be the only way a child expresses that pain. These signs may actually resemble early stages of shock and may be related to fear as well. Use a calm, reassuring voice. Distraction techniques and medications when appropriate when treating these patients. Commonly used pain medications are going to include things like morphine and fentanyl. Intubated patients should receive pain medication and sedation if they are hemodynamically stable. and redosing may be needed depending on your transport time as well. Side effects of opioids are going to include respiratory depression, hypoxia, bradycardia, and hypotension. So keep a close eye on those things may be developing, but realize those are also indications of hypovolemia and that kind of stuff, trauma indicators. So you're going to have to mix the good with the bad. Weigh the benefits and risks when administering these medications, because children in shock or even hemodynamically unstable are not good candidates for narcotics, and it may actually worsen their condition. So you want to make sure that you carefully monitor the vital signs anytime you give them medications. All right, so that's trauma. Let's move on to burns. So the initial assessment and management of a pediatric burn victim is going to be similar to that to what we do in adults, but there are some differences. Remember, children have a higher skin surface to body mass ratio, making them a lot more susceptible to heat and fluid loss. And then there's some worrisome patterns of injury or suspicious circumstances can arise in when we're concerned about some things with abuse. So we're going to talk about some injury patterns that are kind of related to that. Of course, safety is a major concern, and we're going to chart our assessment from the doorway because it can help to identify some early signs of smoke inhalation. Look and listen for airway sounds, respiratory distress, and even soot around the nose and mouth. And then we want to make sure that we make that patient is out of the smoky or the bad area and into a well-ventilated area, so that we're not continuing to contribute to the issues. Estimating the percentage of body surface area burned can influence the decisions on fluids as well as transport. So adolescents use the adult rule of nines. So once they're in that adolescent range, we're going to use rule of nines. For younger children, we're going to modify the rule of nines to account for a disproportionately larger head size. For infants, the head and trunk each account for 18% of body surface area. The arms are 9 and the legs are 13.5 each. The size of a child's palm, excluding the fingers, represents about 1% of the total body surface area. Knowing these things and having this down pat, the rule of nines, having this correct, is going to directly impact your resuscitative efforts for these children. So make sure that you study and you know the difference in these scales as it relates to the rule of nines in the body surface areas of these infants and children in burns. Remember, adolescents we're going to use the adult side, but infants and children, they've got kind of their own set of rules they play by. Always be mindful of ongoing hazards like fire, chemicals, or other dangerous materials that may be around. A quick assessment at the door can reveal signs that there's an issue. So the mechanism or pattern of burns, we may run into situations where there's some burns that are suggestive of abuse, and those are going to be those times when the mechanism or pattern that we're seeing doesn't really match what the parent or the child is telling us, or even what the child is capable of doing. So we want to make sure that we remove any burned clothing and support the ABCs and begin administering 100% supplemental oxygen when we start our treatment for that. Clean the burned areas lightly to prevent hypothermia and cover with a clean dry cloth. Avoid using any kind of lotions or ointments as they can trap in heat and bacteria and all those kinds of things, and some of that stuff can be absorbed into the body. Ensure the burn area and the patient are appropriately covered as needed. Provide pain management as early as possible. And once the patient's condition is stable, we can transport them to an appropriate medical facility that can manage burns. Of course, for large burns and full thickness burns, and especially burns involving the face, neck, or hands, they should be taken to a burn center so that they can receive optimal care. All right. Children with special health care needs. This may be the last topic. I think this is our last topic of this chapter entire chapter, the section in this chapter. But it covers a lot of ground. We have a lot of children with special healthcare needs, and these are those that have a physical, developmental, or learning disability. They can vary widely, and many of these patients have multiples of these issues. These can result from a variety of causes, such as premature birth, traumatic brain injury, congenital abnormalities, or even acquired illnesses. There's a lot of advances in technology and medical treatments and equipment that's out there that have allowed more children with disabilities to receive care within their communities, within their homes. We see a lot more of this happening today than we have in the past. Tracheostomies, when we see patients with these, this is just a surgical procedure that creates an opening or a stoma in the neck that allows for the placement of a tube to provide long-term ventilatory support. Reasons for them having this can be chronic lung diseases requiring long-term ventilator support, neurological impairment that prevents the child from protecting their own airway, and then even some congenital airway abnormalities that causes airway obstruction. These are just a few. There can be others. Caregivers are often a main key source of information and typically carry spare pieces of equipment in emergencies. So when you're dealing with tracheostomies and tracheostomy tubes and ventilators, the caregivers can be very helpful. The child may breathe to a certain degree independently using room air if the tracheostomy tube's purpose is merely to bypass the upper airway obstruction. If the child has severe lung disease or respiratory drive issues, they may rely on a home ventilator or supplemental oxygen full time. Common issues that we're going to see with these tracheostomy tubes is, and typically what we see is an obstruction that's caused by some kind of secretions that are developing, and they plug it up. Tube displacement is another potential concern. This is especially concerning if the parents are very familiar with the equipment and they were not able to replace that tube. This more than likely is going to result in you having to transport that patient to get that tube placed back in. So when we're managing these in episodes of respiratory distress, check the tube's position and suction it if needed. If the child has a home ventilator, we're going to have to disconnect the circuit and provide bag mask ventilations directly to that tube. If the child remains in distress or they're cyanotic or fails to improve, you may need to replace the tube, ideally with one of the same size and length. Hopefully they've got a backup there at the house that they can provide you with, and you can get that replaced. And then, of course, confirm the tube is in the right place as you would with any endotracheal tube. So you're going to listen in the same way, same pattern. A small ET tube may be inserted through the tracheostomy if needed. And then, of course, standard oral endotracheal intubation can be performed as long as there's not a defect issue that would prevent that. Ensure that the ET tube is positioned below the tracheostomy. If not, cover the tracheostomy and ventilate with a bag mask device. G-tube is a surgically inserted tube that goes into the stomach through the skin, allowing direct access to provide nutrition and medications while bypassing the oropharynx and esophagus. So it goes directly into the stomach. Some children rely completely on a G-tube for all their nutritional needs. For other children, the G-tube is used as a supplement to ensure adequate nutrition. Common issues are going to be obstruction, dislodgement, leakage of the G-tube, but these are generally not large concerns, and they don't typically require emergency intervention. Most issues can be managed with supportive care and transport to appropriate medical facility. If the G-tube becomes dislodged, immediate medical attention is necessary. The opening of the abdominal wall can constrict rapidly, which may make the tube replacement very difficult. So when these things come out of place or they get dislodged and that tube comes out, it gets pulled out, we need to transport them to the hospital because it may be difficult if that thing is not replaced quickly, and it may require another surgical procedure to get it back in place. Central IV catheters are used in for long-term IV access, allowing for the administration of medications and or maybe even nutrition. These catheters are inserted into large central veins such as the subclavian vein. There are several types of them. There are a few types of central lines. There's the completely implanted lines. These have a port or a reservoir placed under the skin and may stay in place for months to years. They're often seen in children undergoing long-term chemotherapy. And then there are the partially implanted ones. These have external tubing that exit the skin. Realize many of these types of central lines require a very specific type of connection or a very specific type of procedure in order for us to connect anything to it. So it's why we don't typically connect anything to them in the field. Complications, of course, are going to include infection, which we'll see that with, and they show signs of redness, swelling, or tenderness, maybe even pus around the insertion site. They may become blocked because if it becomes blocked, it could be a true medical emergency, especially if it's delivering critical medications or fluids. And it may even, lastly, it could become dislodged or even break, which could cause leakage of fluids or even blood. Management of the complications, of course, if it becomes obstructed or broken, use a sterile technique to clamp the line off to minimize the risk of infection or an air embolism. If the child doesn't urgently need an infusion, evaluate the situation and, of course, transport accordingly. In rare situations, a child with a functioning central line may require emergency IV access. If possible, attempt to attain peripheral access instead of using that central line to reduce the risk of infection. Once again, there's typically a very detailed procedure for accessing these central lines. So if you need IV access, typically you're just going to start another IV or place an IO or something along those lines and not mess with the central line. Those central lines have, you can't put multiple ones in or make multiple attempts at them. So protecting those is really, really important. So ventricular shunts are used to drain excess fluid from the brain, thereby helping to regulate intracranial pressure. The procedure involves a neurosurgeon placing a tube connected to a one-way valve and a pressure sensitive valve. The valve directs fluid from the enlarged ventricle to the abdomen's peritoneal space. When pressure builds in the ventricle, the valve opens, allows cerebrospinal fluid to flow out into the peritoneum where it is absorbed. Some complications of these is the shunt may get blocked and prevent proper drainage. Also, a blocked shunt may lead to hydrocephalus, which is where that fluid begins to accumulate in the brain and leads to increased intracranial pressure. This can result in symptoms ranging from mild behavioral changes to severe brain herniation. Common symptoms of hydroencephalitis include headache, fatigue, vomiting, and in severe cases, coma. Other complications may be due to an infection of bacterial contamination during surgery or from bacteria in the bloodstream attaching to the shunt hardware. Infections typically arise within the first few months following surgery, so timing is kind of everything with those. And when children have an infection of the shunt, they are usually very ill with signs of fever and maybe even signs of an obstructed shunt. Shunt obstructions and infections are critical conditions that require immediate attention. We're going to transport them quickly to a facility for a neurosurgical evaluation, so we need to take them somewhere that has those abilities. Ensure continuous cardiopulmonary monitoring throughout the transport and detect and manage any other complications as they arrive. Shunt obstructions often lead to symptoms of increased intracranial pressure, that's going to show in late signs in things like Cushing's triad. And other symptoms may include an altered mental status, vomiting, headache, and even changes in behavior in the mild side of things. So, we're going to follow those standard assessment sequences. We're going to follow that typical pediatric assessment steps when we're assessing these patients. And we're going to do a comprehensive evaluation and begin the care. Ask the parents and caregivers to provide detailed baseline information about the child's neurological and physiological status to help guide our treatment. And of course, our approach to the child is going to be according to their developmental stage. And again, this is where the parents can help us. A child with a perinatal brain injury may have development skills of a younger child, even if they are much older. A child with severe cardiopulmonary issues may appear more medically compromised, but their cognitive function may still be very much intact. So the goal of this is we're going to aim to return the child to their unique physiological baseline. We want to collaborate with caregivers to understand what is typical for the child and identify the management strategies that have worked in the past and begin to implement those along the way. Many children with special healthcare needs have designated medical homes such as a hospital or clinic or private practice where they receive their routine care. So they're going to have a home base that they're going to go to. So when there's an issue, the family's going to say their doctor is here, and that is where they're going to need to be transported to. It is beneficial to transport them to that facility where the team is familiar with their care and their history as well as their needs, because this is going to help to streamline their care. If you're transporting to the familiar facility, if doing that is not possible, make sure that you bring any available medical records to assist the receiving team in understanding this child's unique healthcare needs. Take any essential assisted devices, including ventilators, feeding pumps, that kind of stuff, to continue to support the child's ongoing needs during transport. And of course, the presence of the child's parent or caregiver is crucial. Separation can be emotionally challenging for the child, so having them accompany the child during transport is vital to emotional support, so we should consider that as much as possible when we're transporting them. All right, guess what? Chapter 44 is over. We've reached the end of chapter 44. Probably one of the longest chapters in the book. If it's not the longest, it's at least tied for the longest. All right, so we will be back at chapter 45, which I believe is geriatrics. So we're going from one end of the spectrum to the other. So we'll see you guys back at chapter 45.